masterclass.
Okay, let's jump into this scenario then. This is really a masterclass in pattern recognition, I think. We have a 60-year-old woman. She presents with a history stretching back several months. It's a recurrent eruption.
Okay, several months, recurrent, noted.
And it's noticeably pruritic, so it itches.
Yeah.
But the physical characteristics are really where the money is.
Always the morphology.
This eruption is defined by flaccid superficial pustules, and they're arranged in these really striking annular and serpiginous patterns.
Flaccid, superficial, annular, serpiginous.
Location. Across her trunk and her flexural areas, think armpits, groin, that sort of thing.
Common spots for friction or occlusion.
And these lesions, they rupture easily. They leave behind this sort of superficial scale and crust.
Okay, unstable lesions.
And one more crucial piece. A potassium hydroxide prep. A KOH prep from a pustule. It came back negative for fungal element.
KOH negative, that's important.
So given that whole picture, all those highly specific details, what's the most likely diagnosis? Here are the options. A, generalized pustular psoriasis. B, tinea corporis. C, pemphigus foliaceus. D, subcorneal pustular dermatosis, also known as Sneddon Wilkinson disease. E, acute generalized xanthomatous praeculosis, or AGE.
Okay, so faced with this, you really need to zero in. There are, I'd say, 4 absolutely critical pieces of information in that description that should immediately guide you.
4 key clues.
First, maybe even before thinking about location or age, the single most vital descriptor is flaccid.
Flaccid pustules.
Yes. If a pustule is flaccid, it tells you it's incredibly superficial. It's forming right under the stratum corneum, that very top layer of skin.
Okay.
That dramatically limits your differential diagnosis right away. Things that cause deeper pustules are less likely.
Got it. So flaccid means superficial. What's number 2?
Second is the pattern, annular and serpiginous. These ring-like, circular, or sort of snake-like patterns. They aren't typical for generalized acute flare-ups.
Right. They suggest something else.
They suggest a more chronic condition, one that's maybe healing in the middle while it's actively spreading or creeping outwards at the edge.
Okay. Pattern points to chronicity. What's third?
Third is the overall timeline and the course. It's a several-month history, and it's recurrent.
Yeah, that rules out something sudden.
Exactly. It pushes against any really severe acute reactions. And number 4, tying back to your point earlier,
The KOH prep.
the negative KOH. It definitively rules out the most common thing that causes annular patterns with scale, which is tinea corporis, ringworm.
Okay, so let's recap. We have flaccid superficial pustules, an annular or serpiginous pattern, a chronic relapsing course, and negative fungal studies.
Put those 4 together.
And the picture becomes much clearer, doesn't it?
It really does. The correct diagnosis here is D, subcorneal pustular dermatosis, Sneddon Wilkinson disease.
Sneddon Wilkinson.
And the name itself, subcorneal pustular dermatosis, it tells you almost everything you need to know about where it is microscopically and why it looks the way it does clinically.
So let's dig into SPD itself. You mentioned subcorneal makes the pustules unstable. What are we actually seeing when we look at these lesions?
Well, because that pustule is sitting just beneath the very roof of the skin, the stratum corneum, there's almost nothing holding it together structurally.
Right, it's fragile.
Extremely fragile, which is why the vignette specifically said the lesions easily rupture, they break, and then you get that crusting and scaling left behind.
Makes sense.
And sometimes there's this interesting clinical sign before they rupture. Some people describe them as half-and-half pustules.
Half and half. What does that look like?
You might actually see the white pus, the neutrophils, settling down in the bottom half of that little blister space due to gravity.
Oh, okay.
And then clear fluid, serum, might be floating on top. It's quite a distinct visual clue, pointing to just how superficial that split is.
Wow. And what about that pattern, the annular serpiginous thing? How does that form?
It's really just a result of the chronic nature of the inflammation. The condition keeps generating new little pustules.
But where do they form?
They tend to pop up right at the active leading edge of the older lesions that are starting to heal and crust over.
Ah, so it creeps outwards.
Exactly. That continuous expansion at the periphery, while the center might be clearing, is what creates those really characteristic rings or snake-like shapes. And you often see it in those flexural areas, like the trunk folds, groin under the arms.
Okay, that clarifies the appearance. But what's going on underneath? You said the diagnosis has bigger implications.
It does. What's fascinating, and frankly really important clinically, is what SPD is. We classify it as an autoimmune neutrophilic dermatosis.
Autoimmune and neutrophilic. Break that down.
Autoimmune means the body's immune system is mistakenly attacking itself. Neutrophilic means the main weapon being used, the main inflammatory cell rushing to the site, is the neutrophil.
So, our own defenses causing the skin damage. Is there a specific target?
Well, research shows that in at least some cases, yes. It seems to involve autoantibodies directed against desmocollin 1.
Desmocollin 1, that's one of the glue proteins in the skin, right?
Precisely. It's a desmosomal protein crucial for holding keratinocytes, the skin cells, together in the epidermis. So if your body attacks desmocollin 1,
The cells separate superficially.
exactly, you get that loss of adhesion high up, creating the space for the pustule, and then the neutrophils flood in.
Okay, but here's the part you flagged it's critical, the internal implication.
Yes, this is the absolute must-know takeaway. The fact is that this rash, which seems localized to the skin, is frequently associated with monoclonal gammopathy.
Monoclonal gammopathy, like MGUS.
Often, yes.
Yeah.
Monoclonal gammopathy of undetermined significance. And the most common type linked to SPD is an IgA paraproteinemia.
IgA, okay, that is huge. So you're saying this itchy, chronic rash could be the first sign of an underlying plasma cell disorder.
That's exactly what I'm saying.
Wow. Why is screening for that so vital? Isn't there a risk of over-investigating?
It might seem that way, but the risk of missing it is just too high. A monoclonal gammopathy means there's an abnormal production of a single type of antibody, often IgA here, by a clone of plasma cells.
And that can progress.
It can. While many gammopathies remain stable, like MGUS, they are a known precursor or can be associated with more serious conditions like multiple myeloma. The skin is essentially waving a flag, giving you potentially the earliest warning sign that something's brewing systemically.
So it's not optional then?
Absolutely not. We have to stress this. Screening for an underlying plasma cell dyscrasia is mandatory once you confirm SPD. Usually that means doing a serum protein electrophoresis, an SPEP, maybe immunofixation too.
You haven't finished managing the patient until you've looked for that connection.
Correct. You need to rule it out or get them plugged into hematology for monitoring if something is found.
And SPD keeps company with other inflammatory conditions too, right? It's not just the gammopathy link.
That's true. It does show associations with other conditions driven by inflammation, things like pyoderma gangrenosum, those nasty skin ulcers,
Right.
and also inflammatory bowel disease like Crohn's or ulcerative colitis and even rheumatoid arthritis. So recognizing SPD should make you think about the patient's broader inflammatory risk profile.
Okay, that makes sense. Now that we've really established SPD, let's quickly circle back to those other answer choices. We nailed the diagnosis, but understanding why the others don't fit is just as important for learning.
Absolutely. The differentials are where you really hone your diagnostic skills.
Let's start with A, generalized pustular psoriasis, GPP. Both have pustules, but they're very different beasts, aren't they?
Totally different. GPP is typically acute, often severe. The patient is usually quite sick, maybe feverish, might need hospitalization.
And the pustules themselves.
They tend to be more widespread, maybe confluent, running together, forming lakes of pus on top of very red, angry skin plaques. They're not typically these discrete, flaccid, annular lesions we saw in the vignette.
So the timing, severity, and morphology all rule out GPP.
Completely.
Okay, what about B, tinea corporis, ringworm,
That one's easy, right?
the KOH prep?
Exactly. The vignette explicitly stated the KOH was negative. Tinea is fungal. No fungus, no tinea diagnosis here. Plus, classic tinea has more of a scaly, raised border, not usually primary flaccid pustules like this.
Right. Okay, C, pemphigus foliaceus. This one feels closer. It's also superficial flaccid autoimmune.
It is the trickiest distractor, for sure. But the key difference lies in the primary lesion you see.
What do you mean?
Pemphigus foliaceus starts as a very fragile blister, a bulla. It ruptures almost instantly, leaving behind scale and crust. You often don't even see the blister phase.
Ah, whereas SPD's primary lesion is the pustule.
Precisely. You see the pus-filled lesion itself, that's the hallmark. Also, pemphigus foliaceus doesn't typically form those classic annular or serpiginous patterns that are so characteristic of SPD.
Good distinction. And finally, E, AGEP, acute generalized exanthematous pustulosis.
The name kind of gives it away, doesn't it? Acute.
Yeah, our patient had a several-month history.
Right. AGEP is almost always a rapid onset reaction, usually to a drug happening within days. You get tiny non-follicular pustules popping up on red, often swollen skin. Our patient's chronic recurrent history makes AGEP impossible.
Okay, so the clinical picture points strongly to SPD, but for definitive proof, what does the biopsy show? The histology.
The histology really seals the deal. The pathognomonic finding, the thing that defines it under the microscope, is exactly what the name says, a subcorneal pustule packed full of neutrophils.
Right there under the stratum corneum.
Yep, that confirms the location and tells you which inflammatory cell is driving it.
And does histology help distinguish it from pemphigus foliaceus too?
It does, critically. We look for something called acantholysis,
Which is?
separation of the keratinocytes, the skin cells breaking apart from each other. In pemphigus foliaceus, because the antibodies attack the cell glue, you see significant acantholysis.
And in SPD?
In SPD, acantholysis is typically absent or maybe just minimal. That lack of significant cell separation is a major feature helping to rule out pemphigus.
Okay. And since pemphigus is the main differential, is there one lab test that definitively separates them?
Yes, absolutely. The gold standard here is direct immunofluorescence, or DIF.
DIF. What does that show?
Research shows that DIF is characteristically negative in SPD,
Negative DIF.
which is crucial because pemphigus foliaceus, being driven by antibodies against those cell adhesion proteins, would be strongly positive on DIF. You'd see IgG deposited between the epidermal cells.
So a negative DIF in someone with superficial flaccid pustules strongly pushes you towards SPD or other neutrophilic dermatosis.
Exactly right. It's a key branching point in the workup.
All right, so we've diagnosed it, we understand the pathology, the associations. Let's talk management. What's the long-term outlook for this patient?
Well, for the skin condition itself, the prognosis is generally that it's chronic and relapsing. It tends to come and go, flare up and settle down, sometimes over many years.
But it's not dangerous in itself.
The skin part is generally not life-threatening. Annoying, itchy, yes, but not dangerous. However, as we discussed, the overall prognosis really depends on that potential underlying systemic issue.
Right, the gammopathy or potential myeloma link.
If that's present and progresses, that dictates the long-term outlook and requires its own specific management.
Okay, so assuming we're monitoring for or have ruled out the systemic stuff, how do we treat the skin flares when they happen?
The first-line treatment, the real cornerstone of SPD management according to, well, all the guidelines, is Dapsone.
Dapsone. Why is that so effective?
It makes perfect sense mechanistically. Dapsone is known to have effects on neutrophil function and migration.
Ah, so it targets the very cell causing the problem.
Exactly. It helps calm down that massive rush of neutrophils into the subcorneal space that's actually creating the pustules. For most patients, it works really well.
But Dapsone isn't just a straightforward prescription, is it? There are things to watch out for.
Absolute critical point. Before you even start Dapsone, you must screen the patient for G6PD deficiency.
Glucose 6-phosphate dehydrogenase deficiency.
Right, because Dapsone can cause severe hemolytic anemia in people with that deficiency. It's a mandatory check.
And other monitoring?
Yes. You also need to monitor for methemoglobinemia and check blood counts regularly. So while it's highly effective, it requires careful patient selection, dosing, and ongoing vigilance.
Okay. What if Dapsone doesn't work or the patient can't tolerate it? What are the backup options?
Then we move to second-line therapies. These can include things like systemic retinoids, particularly acitretin.
Acitretin, okay.
Phototherapy, like PUVA, has also been used. And for really stubborn refractory cases, you might consider other options like colchicine, which also affects neutrophils.
Makes sense.
Or even escalate to broader immunosuppressants, or some of the newer biologic agents that target specific inflammatory pathways, like TNF-alpha inhibitors, or maybe IL-1 inhibitors.
So a range of options if needed.
Definitely.
Okay, let's try and summarize the absolute key take-homes from this deep dive for everyone listening.
Okay, the bottom line is this. If you see a patient presenting with flaccid pustules, especially if they're arranging themselves in an annular or serpiginous pattern, particularly in the flexural areas.
Armpits, groin.
Right. And if the history is chronic and relapsing, your top differential diagnosis should immediately be subcorneal pustular dermatosis, Sneddon Wilkinson.
And the immediate next step.
Your immediate next thought must be, I need to perform mandatory screening for an underlying monoclonal gammopathy, especially IgA. Don't forget the systemic connection.
That focus on this systemic link really is the most profound lesson here, I think. You know, considering how often SPD demands this screening for plasma cell disorders, it really makes you wonder, doesn't it?
Wonder what?
Well, how many other seemingly minor localized skin conditions that we see every day are actually the very first, maybe the only visible symptom of a critical underlying systemic illness that's just waiting to be diagnosed?
That's a sobering but very important thought for any clinician. The skin is often a window.
Keep those diagnostic clues sharp, everyone. Thanks for joining us for this deep dive today.
Thanks for listening.
We'll catch you next time.